Thank you, Professor Hayam, Dr. Osama, Dr. Abdelbasit. Inshallah, today I'll be discussing in brief if there are a guideline for the management of renal sarcoidosis. We'll go through a short overview of the epidemiology, renal manifestations in sarcoidosis, diagnostic tools, available management plans, and if there is a novel treatment in the scope, and whether we can set a management guideline or no. Sarcoidosis is a multisystem inflammatory disease characterized by the presence of the known non-caseating granuloma. Of course, the activated T cells and macrophage start secreting chemoattractants and growth factors, resulting in the formation of the well-formed granuloma. It typically presents in young and middle-aged adults, and it has a benign course somehow that 2/3 of the patients get well on their own. However, in 1/3, a chronic disorder occurs, and then we start to interfere with the treatment. Even though sarcoidosis is a well-known disease, however, its renal manifestations are yet elusive, and evidence regarding proper diagnosis and management is scarce. Here we can see that for the extrapulmonary affection, renal system accounts for about 5 to 20% of the affections. For that reason, renal affection sarcoidosis might be overlooked, which will eventually end in end-stage renal disease. Renal sarcoidosis can present as simply an impairment in the renal functions with or without abnormal urine analysis. And the majority of these patients also have evidence of active sarcoidosis in other organs, that when one patient presents with something related to sarcoidosis, say pulmonary sarcoidosis, and during the investigations done for the patient, they discovered that the patient has renal affection. One of the most common presentations for renal sarcoidosis is hypercalcemia and hypercalciuria, with a percentage of 17% and 62% for each. Actually, it occurs because the granuloma itself releases 1-alpha hydroxylase, ending eventually an increase of the 1,25 dihydroxy vitamin D, the active vitamin D level, and rendering it resistant to deactivation through the negative feedback mechanisms, which of course ends in hypercalcemia. Additionally, the rise of the active vitamin D causes inhibition of the BTH, which results in hypercalciuria. The mechanism by which hypercalcemia causes kidney injury is well known. It might decrease glomerular filtration rate through causing vasoconstriction in the afferent arterioles. It might cause polyuria and dehydration, through making the kidney insensitive to ADH. It might cause ETN, and eventually it might cause multiple renal stones and obstructive uropathy. Left untreated, of course, the hypercalcemia and hypercalciuria, it might end in nephrocalcinosis through progressive tubular interstitial inflammation, which will end or cause the patient to have end-stage kidney disease. Second is the hallmark of the disease, and the biopsy is the GEN, or the granulomatous interstitial nephritis. It's the most common finding in the biopsies of patients with sarcoidosis. It can clinically present either with acute or chronic renal failure, or it might actually present silent. It can be clinically totally silent, discovered accidentally due to doing a biopsy for another reason, or even post-mortem. Another effect of the sarcoidosis on the kidney is a tubular dysfunction, which might present clinically in different ways, like tubular acidosis, Fanconi syndrome, or urinary concentration defects. Glomerular diseases, they're not common to be found in sarcoid patients. However, multiple lesions might be found. We can find membranous, mesangial-proliferatives, FSGS, or crescentic IgA nephropathy. And of note that there is no clinical or histological characteristics that can differentiate between sarcoid-associated granulopathy from the primary diseases, which also, of course, applies to the treatment plan as well, as we will see. Last but not least, actually, are the obstructive uropathy. These patients might present with stones anywhere in the urinary tract, urethral, or bladder stones. Some patients presented actually with retroperitoneal fibrosis or lymph nodes. Some patients presented with vasculopathy and the terms of granulomatous angiitis, and those present with renal hypertension. How to diagnose? Simply like any other disease, You have to have a suspected clinical picture, exclude the presence of other diseases, and then have an evidence, histological evidence. You mean take a biopsy from the suspected tissue. That's because sarcoidosis is a diagnosis of exclusion. That's why you have to exclude other causes. In the kidney, you have to exclude some conditions that mimic renal sarcoidosis, like allergic reactions to some drugs, tuberculosis, some tumors. That's because sarcoidosis is mainly, it's a diagnosis of exclusion, as I said before, because it's just accidentally discovered during the assessment of patients for other sarcoid affections. Actually, same applies to the investigations, or most of the investigations are non-specific. You might find some proteinuria that might vary according to the patient affection. It might be mild in tubular affection. If glomerular, it will be higher. Kidney affection, if it occurred, I will find impaired renal function tests. Serum angiotensin converting enzyme ACE is often elevated, but unfortunately it's non-specific and has limited sensitivity. However, it can be used as a marker for the disease activity and response to treatment. The core of my speech today is a treatment plan. Why do I treat? In simple words, to prevent end organ damage. I start treating sarcoidosis when I have a major organ affection to prevent the damage of this organ. Actually, there is not much known about the treatment of renal sarcoidosis, and that's because the incidence is low, and much more is known about the more prevalent pulmonary sarcoidosis. And it's impossible to extrapolate these findings to renal sarcoid، يا إما علشان الدراجز are renal toxic، أو أنا مش عارفة الميتابوليزم بتاعهم هيبقى إزاي في وجود renal affection. فطبعا ده مع الأسف بيسيبنا إن there is no guideline to the treatment of renal sarcoidosis. فمبدئيا I have to tailor the treatment that I have according to the presenting symptom of the patient. The most common are the hypercalcemia and hypercalciuria. We might start by hydrating the patient. Saline is preferred. We might start glucocorticoids, hydroxychloroquine, and chloroquine are also used. And then here we can start the duration for a whole of 12 months. The treatment of interstitial nephritis, of course, glucocorticoids remain the cornerstone of treatment. And for some reasons, one or another, the patient is intolerant to the side effects or so, I might add steroid. I'm sorry. I might add a steroid sparing agent like azathioprine, mycophenolate, or another. And in steroid-resistant sarcoidosis, I might go for TNF-alpha, of course. That is for the known role of tumor necrosis factor in the formation and stabilization of the granuloma itself. Here's one interesting regimen actually I found. It advises to start with glucocorticoids, actually with high doses first, and we continue those high doses for about 4 weeks, and then we reassess. If we have a good response, then we can start tapering the steroids until we reach a maintenance of 5 to 10 milligram per day. And then if I don't have, I go to step 2 by adding another immune suppressive agents. الديبيت دايما كان على التوتال duration of treatment. في ناس قالت 12 months، في ناس قالت 2 years. المشكله فيها ان العيانين دول بيحصل لهم very rapid relapse on withdrawal of their treatment. فعشان كده في بعض البيبرز قايله انه انا اطول التريتمنت لعند 2 سنين. Other immune suppressive agents that are advised زي ما قلنا قبل كده، لو في failure of طبعا glucocorticoids او العيان intolerant للglucocorticoid side effects او في severe toxicity، ممكن add azathioprine او mycophenolate mofetil. And then comes the infliximab اللي هم TNF alpha inhibitors. بديهم لو العيان resistant للستيرويد. انا مش بقول عليه resistant او مش ببتدي TNF alpha blockers الا لو انا اديت مع الستيرويدز another immunosuppressive and both failed. ساعتها ببتدي ادخل الانفليكسيماب. طيب others وهل بيستخدموا في الكدني ولا لا؟ الحقيقه لا، معظمهم لا. الميثوتريكسيت هو very common، لكن هو very common مع البلمونري، ومشكلته ان انا I have to adjust it مع العيانين اللي عندهم kidney failure، والادفايس هو ان انا اختار واحد تاني. السايكلوفوسفامايد is used، لكنه used في السيفير cases even قبل ما اجرب TNF alpha blockers. والفلونامايد برضه is used، لكنه used more في الاوكيولر وفي اللونج ديزيز. طيب في experimental treatments in the scope. هو actually ما اقدرش اقول عليه experimental لان زي ما هنشوف دلوقتي ان في واحد فيهم dated يمكن ل 20 30 سنه. المكتوب انه انا ممكن استخدم الثاليدومايد pentoxifylline and rituximab في العيانين دول given the treatment and most of the drugs دي هي بتشتغل كانتي انفلاماتوري، وان الميكانيزم في الفورميشن بتاع الجرانيولوما هو inflammatory in nature ف this can be used for that. زي ما هو واضح هنا البنتوكسيفالين was used as يعني dated back in 1997 لكنه كان used في pulmonary patients وان هو حسن الريسبونس جدا في العيانين دول مع انهم كانوا steroid resistant. فانا اعتقد what's meant by ان هو experimental اعتقد ان هو experimental to be used in the kidney. نفس الكلام applies للريتوكسيماب ان هم استخدموه في كذا patient ولقوا انه few reports reported describing the successful use of rituximab in refractory sarcoidosis, lung, eye, lymph nodes and scan involvement yet برضه مش في الكدني disease. فاعتقد that's what's meant by ان هو experimental in use. طيب can we consider renal transplantation؟ الحقيقه اللي brought الفكره بتاعت renal transplantation to the surface هو age of the patients. Most of these patients present in young and middle-aged age يعني فالdialysis or so will not be the best choice for them to continue their life with. It's not very common الحقيقه بس انا لقيت paper واحده وهي كمان cited في كذا حاجه in a French center who transplanted 18 patients with sarcoidosis. And they concluded that renal transplantations may be carried out safely, but unfortunately, recurrence حصل في 17% of these patients. فأعتقد whether we do or do not transplant these patients لازم تمشي on basis of case by case, assess يعني pros with the cons وساعتها أختار the best decision for the patient. And thank you.